our first guest speaker, we have Chastity Albaugh. She's a manager for front desk operations with Montgomery Medical Associates, PC. So I'll turn it over to Chastity so that she can talk about her experience with her practice reopening during post-COVID. So Chastity, take it away. The floor is yours to speak.
Hi, I want to thank, first of all, MDPCP for hosting this webinar today for the reopening stages of all practices. And thank you for having me as a guest speaker. Thank you, Angelica, for asking me. And thank you to our amazing coach, Tammy Lou, for helping us guide through not only the whole MDPC process, but also through this COVID pandemic time. So just a little background about our practice. We have a multi-specialty practice. We have about 16 providers currently. We do go to nursing homes and hospitals, and we have a home-based primary care practice with our patients where we visit patients at home. So since the beginning of this pandemic, we haven't stopped. We never shut down our office. We resorted more for telemedicine visits during the pandemic. We realized that during the pandemic, we couldn't shy away from our patients and shut down. They have other medical conditions and issues that need to be attended to each day outside of the COVID-19 issues that are going on now. So we didn't shut down, and we realized that we need to be here for our patients in order for them to not resort to the hospital or urgent cares, so that we could let the hospitals deal with the severe, critical COVID-19 patients at this time. So this is all new territory for all of us during this time for the COVID. So as we went on with our practice, we did pay attention to the CDC guidelines, the Governor Larry Hogan's guidelines, and it's all a new process for everybody. So we did take the approach, and we did do a lot of things with our practice. We're learning as we go. Every day is a new challenge, we're realizing. So a few things we did for our practice is we first started with triaging the patients over the phone. We asked them more questions about their symptoms, and then when they came into the office, we did first start having them stand outside. We would come downstairs, take their temperature, bring them inside. They answered a questionnaire about the virus as well, so we had a paper record on file if they did come to the office. If they showed any symptoms at all about the virus, we would offer them only a telemedicine visit with the provider. And telemedicine, we do have a portal we use through Chiron Health, and we do offer any type of telemedicine, FaceTime, WhatsApp, verbal call, anything that we can do for our patients. And we have numerous signs around our whole building, just so we can protect other offices as well. We do start with staff each morning. We take their temperature. We take their temperature in the evening before they leave. If any staff member shows a sign of the virus or any illness, we ask them to stay home. We get tested, and once a negative test appears, we can come back to work free and clear. We did take adjustments to our suites. We have 2 suites in our building, so we did limit our waiting area. We used to have about 10 to 12 chairs in our waiting area. We're currently down to 4, spaced out. We only have 1 to 2 patients at a time in the waiting area. We ask them to only bring 1 guest if they're older and need translation help. They're allowed 1 guest in the office with them. We did also, we do test staff and providers on a biweekly basis. The 1st and 15th each month, all staff gets tested. If we do show a positive patient in the practice, we do communicate very well with our staff, and then we get tested as well. We did have an incident when it first began that one of the doctors came in contact with a positive case. So that provider was stayed home to quarantine for 2 weeks and then tested negative and came back to work. We are doing everything we can for PPE. I know it's limited, so we do have the struggles of finding PPE, but once we do get them, all our staff and providers have been fully equipped with N95 masks, K95 masks. We have gowns. We have shields, face shields, and we will improve each time as we get them for all staff and all providers. We are cleaning after every patient in the office. We have industrial and medical cleaning supplies. We clean all chairs, doorknobs, surfaces, even down to the pens the patients are holding. So the biggest thing to take away from this is we are all new to this. It's a high anxiety ridden virus, and we need to make sure we have a healthy balance for our patients, our staff, patients' families, providers, communication, and we also need to keep in effect that, yes, the safety is first, but we also need to keep our customer service skills as well. What we found is with all these changes with the patients, some backflash because they're not used to having their temperature checked at the door. We're not used to all this new protocol. So just keep in mind their anxiety, your anxiety, always have communication skills with them and customer service, but their safety and our safety is the #1 priority. So if you guys have any suggestions, we ask our staff almost daily. We meet very frequently about the changes we can make from what the CDC is recommending, from what patients are giving us feedback. So if you guys have any questions for us to help other practice start reopening stages, you guys can contact us and we'll give you all our information that we have to help reopen for our patients.
Thank you so much, Chastity. That's awesome. Thank you for sharing your insights and experience on reopening during this COVID-19 pandemic. So we do have our next guest speaker, Dr. Titus Abraham. Dr. Abraham is a physician with Annapolis Internal Medicine, and he's here to also talk about his insights and experience.
Thank you for having me, and thank you to the MDPCP program and all the organizers of this program. The previous speaker basically hit all the highlights, and I basically say the very same thing she said. Maybe add a few differences to what we approached it. Of course, when the governor issued the stay-at-home orders and the recommendations and all the recommendations to CDC to reduce and stop unnecessary or rather non-essential care, the practice essentially sent out messages to patients, closed our schedules. We virtually converted to televisits almost 100% within the space of a week. And our staff worked from home. We sent our staff home with computers, laptops, everything. We closed the physical space plant down. We have a walk-in clinic, and of course that was closed down. And we used that for urgent care needs. So someone who we had no way of managing over telemedicine, they would come in, that patient. So we would have a doctor in a rotating schedule manning that. All the other doctors and nurse practitioners work from home. Our walk-in clinic went virtual essentially also. So any same-day sick went to the virtual clinic. And everything was basically done virtually. Our staff worked virtually. And during that time, we changed some protocols. We would meet by Zoom with the physicians every week, regardless, to sort of sort out where it's going, what's happening, what's the latest news, what are we doing as far as PPE, what are the protocols that we have in place. So it was very interactive, frequent communication, developing protocols, so when things would be starting to open up, we would be ready for it. And of course, as restrictions were loosened, we reviewed our schedule and we decided to go to 50%. So, I'm speaking from my office today, so we're at a 50% in-office capacity. All office visits have to be 30 minutes long, so as to allow a more slower flow to avoid any unnecessary waiting in the room. In fact, we discourage patients waiting in our waiting room. We want to take them back immediately to the waiting room, to the examining room, and we've eliminated checkout essentially. So patients come in one way and they go out a different way. And so, the frequent cleanings after patient visits, we probably only have maybe 4 or 5 seats in our whole waiting room, where normally we would have 20 people, maybe 2 or 3 managed to be there at the same time, if at all. But patients go through the normal protocol, temperature checks, questioning, as far as what their risk factors are before they come into the office to be seen. If a patient has any signs or suggestions of any possible viral illness, including COVID, of course, we advise them to go back home, and we'll do a televisit at that point. We have some imaging facilities like vascular and echo. We have not opened them back up yet. That would probably be a late phase opening for us. In terms, we've also used our PFAC, our Patient Family Advisory Council, to get feedback and advice on what besides the normal standard medical protocol to ensure safety, what do they feel comfortable about? And then we've incorporated some of their thoughts and ideas. As we've entered back into the regular work environment, of course, everyone wears masks. Our building itself, no one can enter without wearing a mask. So staff, physicians, patients, everyone wears a face mask, a face covering, and that's been a requirement in order to be seen here. We still are about 50-50 with telemedicine and in-person visits as we are in this first phase of reopening. We're looking at phase 2, where we are having more inpatient coincident with the state and CDC requirements. We'll still have televisits, and we probably will still maintain the longer visit time for the patients to ensure that there's enough time for the patients to be seen and limit waiting in the waiting room. And this way, we also keep a relatively thin staff here, where maybe half stay here and half work at home. We don't want people in adjoining offices if we can avoid it. So maybe we have staggered offices, staggered staff. That counts for our office staff or MAs, anyone. We've put physical barriers in the front of our front desk, acrylic shields, just so that in the likelihood if there's any droplets or whatever, the staff can feel comforted that at least with acrylic shields in the front waiting area. So much we've done much the same things that the previous speaker alluded to. It's just that we're taking our time, trying to follow the guidelines and ensure our patients feel safe as they re-enter, a normal face-to-face care. As we look to the future, clearly, we want to see things we can automate, such as the check-in process. Before this was an opportunity for our practice to automate many things because we didn't have the same staff doing the same thing. So we adopted a lot of pre-visit registration, at-home check-ins, those kind of things. And now we don't really have a checkout anymore. We do all that after the patient has left. There are pluses and minuses to that. But the beauty of that is the patients don't stay waiting around very much at all. We do have a lab draw station here. And what we've done with that is that patients have to be socially distanced in order to wait for their blood draw. So we've sort of structured it that even if they draw blood, patients are not close together waiting for a blood draw. And so we have an in-house lab that we've chosen not to open quite yet until we, number one, have the volume, and number two, we can ensure a safe flow through the workplace. And back to the automation, we're looking ways to further automate that registration process so that we can do more work before the patients come to the office and limit the amount of face time our non-clinical staff have to do with the patients. We want to maximize, for clinical and therapeutic reasons, the patient has face time with the patient, so to speak, but we want to limit the non-clinical face time as much as possible. The bureaucratic, the insurance aspects, all that stuff. And I think this pandemic and it's forced those changes, and I think those are positive aspects to that change. That's basically the outline of my presentation. I don't know if anyone has any questions or if this presenter has any other thoughts.
Yeah, Dr. Abraham, thank you for that. I was curious to know, it seems like you guys had a rapid response and quickly kind of pivoted to doing telemedicine and supporting remote working a bit. I'm curious to know how were you able to have the providers get comfortable with this normal? Yeah.
It's a funny story because me as a provider, I've always 10% of my practice was telemedicine, always, before the pandemic. And in fact, I gave a brief presentation, I think a couple months ago before this really, shut down. telling to my at one of the conferences, the leadership conferences, that I think we should, as primary care doctors, adopt more telemedicine because I think it's good for our patients, it's good for us. Patients don't always have to be seeing us in the office. I mean, I've always sort of felt that was important, and even before this pandemic hit, I said, we should be doing this as clinicians because it's we shouldn't have patients waiting in our waiting room for 30, 40 minutes just to see us if they could be doing something else with their time. So what I think made the difference is that we were slowly doing it. In fact, I had wanted our staff to be doing more teleworking. I said, it saves them time, it gives us more flexibility. I was already sort of, suppose we couldn't work in our building, suppose there was something happened. So it was sort of the back of my mind in terms of an emergency planning. Unfortunately, sometimes a tragic event has to occur to spur it. It just so happened we just had the right ingredients in place already. We didn't have to think too hard about it. We had a platform, we had the software already there. I had talked to my staff members of other physicians who were doing telemedicine on a limited basis. So when we had to pivot, we already had the playbook to pivot. We didn't have to create much of a playbook. The playbook was already there. It's just that we never activated the playbook. And we just happened, we never foresaw this, but it just so happened we were figuring this would take 2 or 3 years, not 2 or 3 weeks to do this. So I think that would be the answer I would give to you. We were planning, but not planning for this event.
So personally, how did that change you? Because I know you mentioned you do like 10% telemedicine anyway, but I'm sure that you had a more, would I say, strict criteria for, referring the patient, asking the patient to come in to see you if you thought a higher level of acuity of care was needed. So how have you transitioned personally, allowing for more conditions that you would now use telemedicine to
Right.
see patients?
Yeah, so that's a great question. I think, frankly, because Medicare's rules changed, right? Medicare essentially went from restricting telemedicine dramatically to basically expanding it overnight faster than the commercial insurers did. So that made the difference. I think if Medicare had not done that, we would be very challenged to how we would apply telemedicine, from a survival basis also. But, the commercial in terms of medical acuity, you all alluded to the physical exam, and that often there are aspects of that you cannot do in telemedicine, of course. But I will say this: there are a lot of things even you think you can't do on telemedicine you can. There's a lady that I know to this day, who was having abdominal pain. I said, examine your belly, press on it. She would tell me it hurts. I stood in the emergency room. I arranged for surgery for this lady in the midst of this pandemic based on a telemedicine clinical exam, based on what she told me. It turned out she had obstructed, she had a cholecystitis. So certainly I would not do that routinely, but I think it broke down the barriers that we think is possible with telemedicine. We have patients take their own vitals. We tell them ahead of time, Dr. Abraham is doing a Medicare wellness. You need to check your blood pressure, your weight, all these things. Please get that ready for our MAs would do that. Prep the patients prior to exam. The patient can fill out their health risk assessment online. So that all goes into our, so that would not have been feasible pre-pandemic because Medicare allowed certain things. We just developed the tools to fit their requirements. There are limits to what we can do, but listening to that patient, give their history, looking at their face, knowing them as a patient, I think is 80 to 90% of it. So I think there are certain therapeutic aspects that cannot be replicated with telemedicine. You need to see the patient in front of you just to develop that therapeutic relationship. But listening to the patient, as long as they can do a blood pressure, a vital, or weight, there's much that can be accomplished over telemedicine. So I don't think I loosened my standards in any way. I think the rules changed a bit with Medicare and with some of the commercials, and we just followed suit just to fit their requirements. But I find more personal satisfaction talking to patients face to face, engaging with them. But from a clinical standpoint, I did not feel that I in any way had to lower my standards for the telemedicine aspect of this.
Okay, so one last question. I'll pull in Chastity here to also speak to this. So looking at it from a what I say team-based care perspective, normally if the patient comes in, you have your MA help you run the patient, room the patient, and things like that. But with telemedicine, a lot of providers just say, you know what, give me the link, I'll go ahead and get it done. Have you still figured out a way to allow your practice staff that support you with rooming the patient virtually and all the things they normally would do prior to handing off to you? Or how has that changed or been modified during this time?
Yes, I think that's a great question because, you know, the roles change dramatically in telemedicine, right? Because no one's there checking their blood pressure, right? So the role between our patient care coordinator and our MA often blends. But so what the rooming aspect, at least in our experience, and everyone's experience is a little different, is really to prep that patient up. You know, this is what Dr. Abraham needs for your visit to be smooth and successful. Or, you know, during this visit, you know, some of our staff was looking through high-risk patients, you know, who has not been seen in 6 months and who's a high-risk hypertensive diabetic. Do they have an office visit? So we use this as an opportunity. So, you know, the roles really blended dramatically because the MA was not checking blood pressure or doing vitals anymore. They were doing basically a lot of what the patient care coordinators, or so quote unquote clerical staff use, so for lack of a better term, would do, you know, to call the patient. But I think the knowledge that patient knows my MA. So in our practice, it's one doctor, one patient, one MA. So it's a team effort in that sense. So the MA, because she knows a lot of the patients personally, that trust is there. So that pivot, that transition was not difficult because the patient knew who they were talking to on the other end of the line. She knew my MA. Though my MA was not doing the same sort of stuff, they were just sort of prepping the patient or converting an office visit to a televisit, maybe telling them how to do that. But there was a lot of blending of roles in this time period.
Thank you. Chastity, how was that different in your practice?
So with our patients during the telehealth, if we are using our dashboard that we use, Chiron Health is what we use, our MAs do still triage the patient, and then the provider comes on board. But if the provider is just doing like a FaceTime visit or like a mobile app visit that the provider is at the office, then the MA does not triage. The doctor does all the triaging for the patient during that telehealth visit. Our MAs and myself and a few other admin have been in contact with our high-risk members for Medicare, for Johns Hopkins Advantage, for CareFirst, and a lot of other commercial insurances to try to get them seen during this high time because they are a high-risk member for COVID contact, and we have them seen via telemedicine. We offer home visits with our nurse practitioners, or we offer if they're healthy enough and feel comfortable enough to come into the office.
Well, thank you. So, Angelica, I'll hand it over to you for a quick break, and then when we come back, we continue from there. Thank you.
Yes, thank you to both of our two speakers. We do have another speaker that is going to be joining us, and then we'll conclude with Q&A. But at this time, we do want to take a 10-minute break. So the time is 2:45. So we'll reconvene along with our guest speaker and also the Q&A at 2:55. right. Good afternoon, everybody. Welcome back from break. So I know that we're going to have our third guest speaker present, Dr. Joseph Weidner. We're actually going to allow time for Q&A so that Dr. Weidner can join us to share his insights and experiences from his perspective on reopening the practice. So before he's not on right now, but when he does get on, we'll turn it over to him. So we're going to open it up to the Q&A right now. So I'll turn it over to Ashley so that she can lead the Q&A session right now. So Ashley, take it away.
All right, good afternoon, everyone. So the first question that we have today, we'll start with Dr. Haft. Someone stated that they are being denied payment by some insurances for telemedicine. One elderly patient was denied telephone evaluation. Please inform who we should contact for telemedicine payment concerns other than the insurance companies.
So if the claims were appropriate claims and then they were under the rules and regulations that have been loosened during COVID, and they were still denied, the first place, of course, is the insurance company. The second place would be the Maryland Insurance Administration, who oversees the commercial insurers. If it's a Medicare claim, that's not under the guidance of the Insurance Administration, nor is the Medicaid. But if it's a commercial claim, it would be there. Medicare, it would be back to Medicare, or Medicaid would be back to Medicaid administration.
Okay, awesome. Thank you, Dr. Haft. Looks like the next question we have will be for Dr. Abraham. And the question states, the next question states, how would you recommend physicians address collection of retinal eye exam and test for their diabetic populations this year?
To answer your question, I think process has not really changed. Let me just change something here. Yeah, and to collect retinal eye exams, we've looked into things like Retina View, but I don't think we have any better answer than anyone else. We're encouraging patients to get their retinal exams. So I don't know if that's what the questioners are asking about, but our process has really changed. The ophthalmologists have to be able to do the exam unless we're able to incorporate some technology in our office, which there is available, things like CareView, but we have not tried to do that seriously. We're focusing on the big picture, the A1Cs, making sure those patients who have not been seen, who have not gotten lab work, that we get them at some point or even order through televisit. But the retinal exam will be a challenge.
All right, thank you so much, Dr. Abraham, for your response to that question. So the next question that we received in our chat today is for Chastity. Are the 15-minute tests for COVID accurate? And is the testing in the office reimbursed by third parties? And that's also for Dr. Abraham also. So if you both would like to respond, that's perfectly fine.
They're asking about the virus or the antibody?
So, Dr. Abraham, I think the question probably is about the PCR test, the rapid PCR.
Right. Yeah. So we have not tested here in our office because of the PPE requirement. There's so many places where they can get tested now that we are not concerned about access for testing. I think we'll have to rethink our process very carefully because it involves exposure. So we are not doing any testing that involves possible exposure to aerosols. As far as reimbursement, I can't comment, and I'm not aware of any issues with that because we're not doing that in our office.
So I'm happy to add just a little bit more to that, but certainly, practices can, if they choose to, and use PPE do testing for PCR in their office. In regard to the reimbursements, that there is both a code for COVID testing that is just testing alone, or it can be included as part of an E&M visit, if it's included in an E&M visit. So either of those are allowed by Medicare and most payers.
All right, thank you so much. So it looks like our next question is going to be for Dr. Okeke. If a patient gets a COVID test before an appointment and tests negative, do we still need to use PPE and disinfect after each visit?
I would say that using PPE is definitely a precautionary measure. So if you have a routine in how you before the patient arrives, the safety procedures you normally would do, before they do, when they do, after the patient leaves. I think if you just keep it in that sequence, it helps so that you're not, kind of thinking about when you turn on the switch, turn off the switch. So regardless, we are in a pandemic and people can show up symptomatic, asymptomatic. And again, remember, you're not only protecting yourselves from the patients, is a two-way street as well. So I would say if you have a protocol in place for patient safety, just maintain that as a routine.
All right, thank you, Dr. Okeke. We received another question that states, have either of the two practices had any issues with providers resisting seeing patients, even with the institution of best practices for patient and staff that were outlined?
I can answer that. We had some hesitation, but I think we've discussed the best science we have so far, what kind of PPE we require. So we haven't had any serious objection. Some concern, but no objection.
Thank you so much.
So for our practice, we haven't had any resistance with our providers with telemedicine for seeing patients.
All right. Thank you, Chastity.
Thank you.
Any other responses to that question for any of the practices? Okay, so next question. For the guest speakers, how many patients do you allow in your waiting room at one time? And also, how long in between a patient being seen do you wait to use the room again?
I don't wait any particular time when a patient leaves the room, as long as it's been cleaned down. So as long as the touch surface has been cleaned, there's no waiting, there was no aerosolization. Patients are wearing masks. As far as the waiting room area, I haven't checked, but we really should not have more than 2 people in that waiting room, if at all, if any at all, because our goal is to, as soon as they enter, they're moved to the waiting room, moved to the examining room, and there should be no effective waiting room. We don't even really have a checkout space anymore.
So with our practice, we're only allowing the max number of people in our waiting room at 4 total. We do have them triage to the back within about a 2-minute process of check-in. And then for when they exit the exam rooms, it's immediately cleaned, sterilized, the exam tables, the chairs, the surfaces on the countertop, and we wait about at least 10 minutes before entering another patient into that clean room.
So Dr. Abraham and Chastity, just a follow-up question to that. So how would you handle a situation where a patient is late to their appointment and therefore there's sort of a backlog, and do you cancel the appointment? Do you have them wait outside because you have your, in your case, Chastity, no more than 4 in the waiting room, and for Dr. Abraham, no more than 2?
I have not encountered that situation yet, but I think we would have them wait in their car, or if they were very late, ask them to reschedule.
Okay.
For our practice, if we have our max capacity in the waiting room and a patient does arrive late or another patient arrives on time for their next appointment, we do ask them when we go to the door to take their temperature to wait in their car, give us a correct cell phone number, and then we would call them once we have a opening in the room so they can come upstairs and be seen. But we do not cancel any visits.
All right, thank you for your responses. And actually, in addition to that question, someone asked about how many patients per provider would you say you're seeing in the office daily now?
My days are long because now every visit is a 30-minute visit. So I'm seeing fewer patients, but it's taking longer. So I'm seeing them through lunch. So I would say I'm probably about at 75%, but it's taking longer to see those patients.
For our practice, we're seeing about, I would say, anywhere from 15 to 20 patients a day, but that is with telemedicine visits as well. And the providers are going about every 30 minutes for appointments with telehealth and for in-office visits. So our days for the providers have been a little bit longer for them.
Awesome. Thank you for the responses. Next question for Dr. Okeke. Can you require staff to use accumulated PTO as compensation if you send them home?
Sorry, I was on mute. Yeah, that's a very familiar situation. The good part is that we have the Families First Coronavirus Response Act that employers are supposed to read through, modify whatever provisions and policies they have for PTO. The key qualifying reasons for that particular benefit includes if you are asked to be quarantined for any reason, or you actually have symptoms and you're actually sick. So your employers should be thinking through it. Again, be patient with them because this is new for some providers, especially smaller practices rather than the larger ones. So engage before you need it to ask what are the updated policies around PTO and taking time off. But just know that at least there is a federal law out there that supports employees just in case they have to miss work due to COVID or COVID-related support, and also if you have to take care of a loved one or a family member who has COVID, that you also would qualify for that PTO time.
For our practice, this is Chastity. For our practice, any employees that have anything related to COVID illness or a family member with COVID illness, we do continue to pay them if they have to miss work.
All right, thank you, Dr. Okeke and Chastity. So next question is for Dr. Abraham. Regarding the physical barrier on the front desk that you mentioned, who would you recommend some of our attendees contacting if they would like to get this barrier for their offices?
You have to either a partner who's very good with their hands, or you'd have to contact the general contractor who can do that. One of my partners does carpentry, so he's able to do it. I also know someone who's a general contractor who would have been able to do it. So I think it's just, I don't think it's anyone special. I think that's being done a lot more in the community. A lot of carpenters and general contractors have repurposed their business to do this since it's widely being done. In fact, it's hard to find the raw material now. But I don't think it should be hard to find someone to be able to do that. Anyone who's doing any handiwork or any general contractor should be able to do it.
All right, thank you, Dr. Abraham. So we have a general question for anyone that would like to respond. If you are seeing a healthy patient for routine care in the office, what PPE would physicians and MAs wear? Would it be only mask or mask and face shield? And what about gowns?
I can answer. For currently, I think the mask is the bare minimum. And we were always wearing masks, not an N95, but just a regular surgical mask is fine. But the critical thing is having the patients wear the mask also, because the masks we wear are not necessarily protecting ourselves perfectly. If we were doing something like testing that may involve aerosolization, then you need an N95 black gowns, gloves, but just a routine exam. The doctors and the providers use a surgical mask, and the patients are also required to wear a mask, and I think that's critically important.
For our practice, we have the patients wear masks, and for our MAs, front desk, and our providers, we have them actually wear a gown all day, gloves, and a face shield and a mask as well, just in case there's any COVID intake that they haven't known about the patient. And also to go back on the check-in process and check-out process, the shield to cover the front desk, we do have our company works with a furniture company local in Frederick, Maryland. It's called PVI Office Furniture. They are offering the shields, and they're offering like little stands for hand sanitizer and stuff, so if you want to look into that as well.
Thank you, Chastity. So the next question states, hello, we are a pediatric practice. Flu season is around the corner, which means strep tests, flu tests, CDC, RSV testing, etc. What are practices doing other than PPE when testing patients?
We haven't begun that discussion yet, how best to do that. We probably will end up testing them outside of the rooms, maybe in their vehicle or something like that, but we haven't formalized the protocol yet.
We have tested outside in the car for patients that need to be tested, so we're on a protocol to see how we can bring in patients into the office to be tested, but we're doing it out in the car currently.
Yeah, and I can also speak to some of my colleagues, at least the primary care providers at Hopkins. Anything that has to do with additional testing for respiratory symptoms, they refer and have that done in a more controlled space in the lab, and just in case. So not sure if that's something that you would consider. As Dr. Abrams said, people are still trying to figure it out, but just to reduce exposure, it might be something to think about right now before the flu season comes in full swing.
And Dr. KK, we've heard in previous webinars from our pediatric colleagues that some of them have just established one or two staff in a particular area in the offices just for that purpose. So they had the staff appropriately gowned and gloved and exchange PPE as needed for doing those larger scale testing, and or they have taken certain times during the day or certain days during the week to do those kinds of tests also. So I think what we've heard was a lot of creativity, all about being able to make sure that you're keeping a single staff member focused on that, using appropriate PPE, but conserving it and allocating to certain areas in the office for those high volume kinds of things as other strategies.
All right, thank you all for your responses. Next question, does anyone have a protocol for hospital discharge follow-up visits in the PCP office for COVID positive patients?
For our practice, our protocol for discharge positive COVID patients from the hospital, we follow up with them via telemedicine, and we retest them, send them order to be retested until they show a negative test, then we re-enter them into the office to be seen physically.
Thank you very much. Next question, has anyone actually experienced an employee who tested positive for COVID? How did you handle that as it relates to practice operations, and how did you deal with employee heightened anxiety in the office?
Yeah, we've not experienced that yet.
Well, that's not a bad thing. So we're grateful to hear that. Next question in our chat. Have there been any changes to quality measures involving controlling high blood pressure? HEDIS measure guidance clearly states that BPs taken at home are not able to be used to satisfy the measure. If we have a surge or second wave, this may be an issue across multiple payers for this measure.
Dr. Haff, I don't know if you want to take that, but I can take a stab at it, because what we are seeing is really an unprecedented event, and a lot of things we are trying to figure out. Some things are moving faster, some things moving more slowly. I would just suggest if you do have BP recordings taken at home, however, many times you have that recorded because every time you see the patients, you have to record vitals, especially if they're hypertensive. So I'll say go ahead and do that, document that as you saw in the medicine video, indicate that that's subjective as well. And in due time, these are part of the things to have that conversation in terms of the national and state and local leaders about quality, and see what else can be done under those circumstances. Of course, if there's an opportunity to have the patient come in with the appropriate, PPE and protection and patient safety procedures, you can eventually have that BP taken in a office, in your office or in the practice. But that's what I would say to that. But Dr. Haft, do you have any other thing to share about that?
Yeah, yes. So I think that what you said is exactly right. I think we're now in the process of developing flexible policies, and it's on a either government payer or private payer, one at a time, are developing those policies. The best guidance that we received were things like for the annual wellness visits to say that you could submit a claim. It could be done by telemedicine. If the patient had a blood pressure that was measured at home, that could be submitted as a blood pressure. If not, the prior blood pressure from the office could be submitted, and it would be best to also document at a subsequent visit another blood pressure when there's a face-to-face visit. But so I think it was flexibility was the it was the operant word to do what you needed to do that made sense, and I think we'll all find out the policies, the payer policies, will adapt to that in the future. I think part of the process now will be advocating for that flexibility to remain. I know a lot of the policies that exist for telemedicine, for instance, would abrogate towards the end of July if the national state of emergency goes away or expires at that time. So there's an ongoing discussion in the federal level about how much of the good policy that came out as a temporary policy should be preserved regarding telemedicine. It's our hope that a lot of that will be, and I know a lot of people are advocating for that. So I'm sorry that's not a specific question, a great specific answer with great authority, but it's as much authority as we're given right now.
Well, thank you so much, Dr. Haft and Dr. Okeke. Dr. Okeke, we have another question for you. Are physicians held liable if a patient contracts COVID from a doctor or staff?
Very interesting. I think you walk a fine line, but the good part is that back in March, the Trump administration did pass the CARES Act, the Corona Aid Relief and Economic Security Act. And therein, there is this law for a Good Samaritan. And the language does say that you are going to have some protection, because you are in the business of, saving lives. So hopefully that is something that folks are exploring in a more defined way. I would say key associations like the AMA also have written a letter to the National Governors Association, also urging for, these provisions to be, passed and have more details around how to protect our, essential workers, frontline staff, and providers and physicians as well. Dr. Haft, I'm not sure if there's anything specific to the state right now in regards to the CARES Act to protect providers from liability.
So there is some, general immunity clauses that are available in terms of testing and those kinds of things. But the bottom line in this is that in our legal system, anyone is capable of engaging in a wrong tort act against anyone else. Usually the immunity clauses will not protect you against having claims made against you for any reason. But what does protect you is adhering to guidelines and best practices. And in general, the outcomes from, even if there are negative outcomes in cases of any kind, if the individual who the claim is against has clearly adhered to best practices or within community guidelines, then it's generally protective. So I think that's the overwhelming indication here is if you do things that are within the CDC guidelines or within best practices, and you do it in behalf of, in good conscience, good clinical judgment on behalf of your patients, that there's always a concern about being sued for something or held liable, but the concern is minimal compared to the good that can be done.
All right, thank you so much. Next question in regards to video visits. So this is a general question for any of our panelists that would like to answer. What platform does practice staff use for video visits currently?
I can answer this. After this, I'll have to leave the call. I apologize. We use a platform called doxy.me, doxy.me. Our own software is embedding a telemedicine platform, but that's in the beta stage. But the one that we're using is doxy.me.
We're using doxy.me as well. We're also using Chiron Health, and those are the two portals we're using. And then we also use FaceTime, WhatsApp, virtual call, Zoom, Skype, anything the patient can use with us.
All right, thank you. And are any offices seeing drug reps at the moment is another question we have in the chat.
Currently for our practice, we're not seeing reps yet. We're going to start transitioning to see reps shortly, and we're also going to follow the protocols that they must wear masks and have their temperature checked, and limit the social distancing with the providers. But we are doing like a virtual FaceTime visits with them if they want to discuss any medications with the providers.
Awesome. Thanks so much. Next question. In regards to pregnant or high-risk staff, one of our attendees wants to know, are you violating ADA laws if you require pregnant or high-risk staff to stay at home during this time?
So I think pregnant and high-risk staff should be afforded the opportunity to, if they can telework, to telework. If they can't telework, they should be given opportunities to be protected with PPE and do jobs that expose them less to potential patients. But I don't believe it violates ADA by either having them work or not having them work. I don't believe American for Disabilities Act. If they can ask for reasonable accommodations, and request those accommodations should be a individual's condition, pregnancy. Dr. KK, what's your non-legal opinion?
I would agree with you. As a mother, I've had instances where I was pregnant. I think during the last SARS, I was in that situation and had to be at work. So you're right. Protect yourself as much as you can if you still want to be in that line of service. But if you can telework, then do so as well. Again, this is back to what we talked about your staff safety policies and self-care policies for your patient and for your practice staff. So start thinking along those lines, because these things should be a conversation you have and think through what you put in place before you need it. So hopefully you don't have all your front office staff or all your MAs or support staff pregnant at the same time, but it's something to think about, because yes, you can accomplish a lot doing telework, as Dr. Abraham has said, but how do you begin to plan for those uncertainties so that it's not a big impact to the practice, the patients you serve, and definitely for the the employee or the practice staff in particular.
And in general, if you are involved in an ADA or an EEOC complaint, we're not providing legal guidance. You should seek legal guidance for anything that rises to that level.
I agree.
Okay, thank you very much. Dr. Half, we have a question for you. Is there any thought about how much less URIs and flu we may see because of the isolation and hygiene precautions we are using now?
So that's a very good question. I presume that the precautions that we use that protect us from this airborne disease will also protect us from any other airborne disease. So we should anticipate that if people are adherent, that there would be less flu and less flu or colds, etc. I think that would be interesting to see. I don't think we have data on that yet until we get to the flu season. But it's an absolutely an excellent question, and something I'm sure we'll see some of in the literature very, very soon as we move into that season.
All right, thank you. This is Angelica again. I wanted to jump in. We do have our third guest speaker, Dr. Joseph Weidner, that has joined us. So we'll pause on the Q&A for now and reconvene after we hear from our third guest speaker, Dr. Joseph Weidner, who is a physician at Stone Run Family Practice. So Dr. Weidner, I'll turn it over to you so that you can share your insights and experience on reopening. Okay, so while we wait for Dr. Weidner to join audio, we'll reconvene with the Q&A. So Ashley, I'll let you know when we do have Dr. Weidner on the call to speak, and he has the audio. So if you can go ahead and reconvene with the Q&A, and then I'll let you know when Dr. Weidner is available.
Sure, no problem, Angelica. So our next question in the chat is in regards to billing, and it states, are we able to bill telehealth visits with a case manager? And it's a general question, so any of the panelists can respond.
This is Joe Weidner. Can you hear me now?
Yes, we can.
Great.
Hi. Yeah, thanks so much. I'm going to pick up, and hopefully this audio will work. Thanks for your patience here. So, yeah, you had all just talked about reopening, and I think in a way we had been in a way of transforming our practice from seeing more people outside in an outdoor clinic and trying to utilize the fresh air for keeping things safe in a way, but are slowly transitioning patients back in to our office. You know, looking at the slides and hearing some of the things that were said, it really just speaks to how staffing roles have changed in a way. Right now we have a staff person at the door who is kind of like, acts like our bouncer, who keeps people there and checks their temperature and asks if there's symptoms there, as well as kind of manages our exam rooms, because we don't have a waiting room right now. But we have people wait in their cars if they're going to be seen inside. We bought a paging system that has these coasters like you see at a restaurant, and page people when their exam room's ready and then take them directly to the exam room. And so that tries to reduce the amount of exposure patients have to other patients, as well as keeps the staff safe as well. We've looked at air handling systems as well, and have developed one exam room that had an existing exhaust fan and upgraded that to be a negative pressure room. So for that patient who has, you know, some significant infectious process or known to be COVID, we can feel more confident in evaluating them inside now. Although presently we're still we're waiting to install some glass or plexiglass up front to kind of prevent infections coming to our front desk staff from patients, and until we get that up front, we're still evaluating patients outside in a daily outdoor infectious clinic where we do the COVID testing if needed. We've had a daily clinic that we staff with one team each day that will see all the patients that have any types of infections, and have done that since mid-March. Initially, we were under some tents, but we built a more kind of a porch off of a storage container that allows us to have a lot of breeze blowing through and kind of is a more secured area. So we've seen about 270 people, tested 270 people outside of patients of ours for COVID there. One thing that I think really helps us make changes quickly is a daily meeting with all the staff in the entire office, front desk and clinical staff, to talk about changes every morning as part of a daily huddle that used to just be care managers and providers, is now all staff. And I think that's really helped facilitate incorporating some of these changes too. But we've brought more people in, structured our schedule so that we have about 1 out of every 3 visits blocked to just have some time to clean the exam rooms, where the medical assistants will wipe down the table and chair and counters with a virucidal wipe, and they have enough time to let that dry so we can have that cleaning done between patients. And those were some thoughts I had about how we switched from evaluating people outside primarily to bringing more people inside, particularly those who don't have infectious symptoms at this time.
So Dr. Weidner, as a follow-up to what you just shared with us, how have you explored or tried to entertain, if I would say, telework amongst your practice staff? Is that something that you are thinking about, something you've already done? And what does the future look like? Would you consider that now that you know it's possible to still be efficient, productive, and provide comprehensive patient care, if you consider a part of the work being telework?
Oh yeah, I mean, we've been doing telemedicine visits as part of our practice for the previous 2 years. We utilize the DoxyMe platform, and more recently, Doximity has a video call feature that we've been utilizing too. So, prior to the pandemic, we utilized it a lot for follow-ups with ADD patients and people with psych issues, because they required, less of a physical exam, and I think we're more amenable to a telemedicine visit in a number of ways. But yeah, in March we had shifted the majority of our patients to telemedicine. Now, some of them we had as a bit of a hybrid visit, where we realized we wanted to examine part of them, and we'd have them be on their phone out in our parking lot. We'd take the history for the most part in the telemedicine way, and then maybe go out and listen to their heart and lungs, and then finish the visit with a telemedicine visit. So it would be kind of this hybrid type of visit that would minimize our contact with the person, where we were, wearing PPE while evaluating them outside, and utilize it that way. We've continued a number of telemedicine visits, but I really get concerned that the literature isn't strong on how telemedicine is useful with acute care. And so with acute care visits, we're less inclined to do that. I found that utilizing it with wound care has been somewhat helpful, especially if I can have a patient at home with a home health nurse be the one who has the camera and can also do measuring and look at the wound. And that's been helpful for about 3 or 4 patients who have managed their wounds remotely over the past 2 months. You can't do everything with that. Certainly you can't debride a wound, but you can get some level of care that I can feel confident is good there. But for those people who are at a high risk to come out, who you're following up for some chronic conditions where there's not any apparent acute need for an exam, I think it still works and we're still utilizing it. Although right now I think our visits are probably more like about 20 to 30% telemedicine, maybe a little bit less and more inpatients right now. And then, probably about, I think we're averaging 5 or 6 visits outside still in our infection clinic.
Yeah. So one more question for you when we go back to the Q&A session so other participants can ask you questions. I know we talked about this already, but you have done a great amount of work in identifying the best ways to communicate with your patients, the best communication channels and frequencies, what to say, what's too much, what's too small. Can you share a bit about how you come up with that approach to communication, meaningful communication to your patients to kind of calm them down and see you as their trusted primary care provider? And how would you keep thinking through modifying that communication planning?
Well, I think sometimes that communication starts with relationship. Now we've been, pretty well established here for a while, so most of our patients are established patients. Some of the platforms that we use include our website and on Facebook, where we put out a lot of messages to people that they look at. I think probably a good more than 50% of our patients also have portal messaging, so we can send out a group message through there about what types of practices we're doing. I think it's reassuring for some people the measures we're taking in the office, and when they're hesitant to come in, but we feel compelled that we've really got to lay hands on them, is to tell them that there's not a waiting room, that we're going to be checking your temperature like we do everybody here. It's going to be right back in the exam room. Some of the best practices I saw that came out of a clinical handbook on COVID that the military was using spoke to putting a HEPA filter and a UV air purifier in each exam room. We've been doing that to try to help keep that clean. So just giving those messages to the patients that these are important things to do. I think there's a lot of questions about, from the other end, from patients who say, do I need to do anything? Is this real? And really just an ongoing education process about what we're seeing, what truly is happening, how COVID is contagious, and what type of measures we'd recommend they take. That involves, that's more of a conversation that happens when we're doing some testing or evaluating somebody with infections as well. Our front desk is very much in touch with people, more so now by phone. I think more than ever, because a lot of direction needs to be made when they come in for the infection clinic. We want to know their car, make, and model and give them directions on what they're going to do. But also we're collecting all their co-pays on the phone prior to them coming in to minimize the interaction they have in the time in the office. And then when there is a recheck, we're calling them to reschedule that. We had a staff meeting today, and I just wanted to make sure, but my staff loves that. They think it works a lot better in some ways to do that. They feel like they can really manage patients' care better by doing that type of conversation up front before their visit, and then also that follow-up visit too. So those are some things that have changed in our manner in communication with patients there. I'm not sure if you had any other specific questions about communications that you were thinking about, though, with that question.
Oh, that's good enough. And I think your website has a lot of links to, how to check a BP at home, how to, build a mask and stuff, just simple things that your patient can refer to. So that's also something to throw in there that I know that you do it, that's your practice. No,
one other thing, I think we really taken on the role of being more of a point of truth of education, because there's a lot of nonsense out there about COVID. And so, we've got a website that has a lot of links to information I think is pretty solid. A lot of it's from the CDC, but other places on just the role of masks and of different measures that people take, and so that we can have a reference to that we can refer people to for more information. Yeah, that's all I was thinking when you said that.
Yep. Thank you. Angelica?
Yep. Thanks.
Sure.
Thanks, Dr. Weidner, for sharing your insights. We're actually going to reconvene with the Q&A, so please feel free to stay if for any questions that are asked, and if you want to share your experience to try to ask those questions, answer those questions, that'd be great. So Ashley, I'll turn it over to you to reconvene with the Q&A.
All right, thank you, Angelica. So Chastity, we have a question for you, just wanting to know, can you give the name of the company that you spoke about earlier? Was it PVI that you named?
Oh, I was muted, sorry. Yeah, it's PVI, P as in Paul, V as in Victor, I as in Igloo, office furniture. They're located in Frederick, Maryland, and they serve Maryland, Virginia, Delaware, and Pennsylvania.
Thank you so much. We have a question for Dr. Weidner. Dr. Weidner, you mentioned HEPA filter units in the exam room. Can you please elaborate on that?
Yeah, sure. Honeywell makes some standalone HEPA filtration systems. The only reason I thought of this was early on back in March, I was talking with another family doc who works with the military. He was looking at a COVID handbook that was out of Zhejiang Hospital in China, and they had recommended this. I don't know a whole lot about HEPA filtration, but really the rating on these looked like they were going to filter the size of particles that were even smaller than the virus size, so I thought it may be useful. Honeywell makes a unit or two that seemed to be pretty good and had a good review on Consumer Reports. And I could get you the exact model in a minute where I pull up my email that, from the order from Amazon. But let me see. Where was that? I don't know. Go to the next question. I'll find that email. Get you the make and model.
All right, we'll circle back to you. Thank you, Dr. Weidner. So next question, Chastity, another one for you. What questionnaire does staff use for symptoms checklists that you mentioned earlier?
So our questionnaire is, have they traveled outside of Maryland within the last 2 weeks? It's a yes or no. Have they traveled outside the country within the past 3 months? Have they been in close contact for a positive coronavirus patient? And have they been tested themselves? And are they having any of the following symptoms, such as cough, fever over 100, or shortness of breath? If those are all no's, the patient's fine to be seen. If any of them are yes, especially the symptoms, then we directly put them in a room right away, shut the door, get the provider, full PPE gear, and then the provider sees the patient to determine whether it's coronavirus related and needs testing, or it's something different.
Awesome. Thank you so much. Next question. Go ahead, Dr. Weidner.
Yeah, I'm sorry. Yeah, let me just interject. The unit was a Honeywell HPA 300 True HEPA air purifier. That's the ones we use. Thank
you so much, Dr. Weidner. Very helpful. Okay, next question. Can MDPCP funds be used for the purchasing of telehealth platforms and/or equipment?
Dr. Happ, if you're on mute, you can unmute when you can, but I can share a little bit more. For the MDPCP program, the care management fees have restrictions. You have to use them for care management, care coordination resources. The PBIP has some more flexibility. Now, with COVID-19, I can only imagine if that's a resource you have to use to buy into any of the platforms. I would want to, first of all, socialize that there are free platforms. I also know that I think in partnership with MedCai and Care First, I think they also have a platform called Doctor First. You can use it free for the first year. So I would advise at least explore what's available and free, and then you can now consider ones that you need to invest in and spend money on. But to the extent that PBIP can be used now for expanding on telemedicine applications, I would want Dr. Happ to speak to that specifically.
Thank you, and again, yes, and I was doing very well, but I was on mute. So PBIP can be used for anything that the practice chooses to use it for. And for those of you who are in the Maryland Primary Care Program, we again want to remind you that the 2019 PBIP, the first year's PBIP, that the CMMI has agreed to not claw that back. So there will be no clawback of that PBIP at all. So you're certainly free to use whatever you might have reserved from that for whatever purpose you choose. Care management fees can be used broadly. There's a list within the participation agreement of things that specify for what it cannot be used for. And I would just refer you back to that list of prohibited activities for the care management fees. And it's a fairly short list.
Awesome. Thank you, Dr. Haft and Dr. OKK. So we have another question. If an employee tests positive for COVID-19, are you required to record an OSHA incidence?
I don't believe so. I don't, I think that an employee testing positive in this setting is healthcare worker is not a unique incident to my knowledge. I think that certainly if it tests positive, taking all the appropriate precautions for healthcare workers to test positive in terms of whether they're symptomatic or not symptomatic, and following those guidelines and the return to work guidelines. But I don't believe that there's an OSHA requirement for reporting that. Of course, there is a reporting requirement for every COVID positive patient that needs to be done for the health department. It is a reportable disease.
Thank you so much. So next question, does anybody have any idea what percentage of primary care practices are doing testing at their offices versus sending to one of the state-run testing centers?
So I can give you some results on what the Larry Green Center has been surveying for the last 14 weeks. I don't have a specific result in front of me, but it's in the range of, for Maryland, it's in the range of 15 to 20% of the practices have been doing testing. So it's a relatively small number. And most of the reasons that have been stated for not doing testing have been lack of PPE. I would point to the fact that PPE is now much, much more readily available, either through local health departments or through commercial suppliers than it was even a month ago. And the state has quite a lot of PPE in their warehouses, and hospitals are fairly rife with PPE now also. And last thing I'll say about that is that the state overall, the Department of Health and the governor is encouraging broad-based testing. So if practices are willing and able to test, they're encouraged to do so. It's probably the best way to be connected to the actual test and then result for your patient is to have them done within your office itself, and they'll come back through your commercial laboratory system, which is probably the most direct way to do that. And there are billing codes for testing. If you wanted to set up a testing arrangement for people who come in to be tested who are within the guidelines, which are very broad now, you could set up a separate portion of your office for testing and just bill for the actual, not for the lab will bill for the processing the test. You can bill for taking the test and for interpreting it, even outside of an E&M visit.
Awesome. Thank you so much. Next question states, if a practice wants to do a drive and or walk-up clinic in the parking lot, does MDH require any special certifications or on-site before this can begin?
The Department of Health does not require certification. There may be other county or municipality related rules and regulations or regulations that govern outdoor activities or land use and those kinds of things, but none from the Department of Health.
Thank you. And for the practices.
Although this is Joe Weidner, just into that question, that it may be worthy to just check with your malpractice insurance before you go outside. That's what we did, but they didn't have an issue with it, and they didn't require any additional rider to have an outdoor clinic like we've set up at Stone Run.
Thank you so much. Okay, so final question. This is going to be our wrap-up question for the Q&A session. It seems that we should continue telemedicine for most cases in transition to in-office with the safety guidelines mentioned. Is this correct?
Well, I'll start, but I'd really love to hear from our other our practicing providers. I think that now that we've opened the door more widely to telehealth in general, whether it's for the things we did for COVID, or whether it's now going to be for physiologic home monitoring or other kinds of things, it's going to be hard to go back. It's going to be hard to put that genie back in the bottle. I think to the extent that that rules, regulations, and payments continue to be relaxed, I think it will be an increased part of the activities that we'll normally do because of the discovery of some efficiencies, because of the safety factors that occur when you do telehealth for certain patients, whether it's now in high-risk patients for COVID or whether it's high-risk patients for flu season. But other things will be hard to go back. We will go back to there are other things that make it really hard to do that without face-to-face visits. So I think we'll see a hybrid version, which will be better than either the full telehealth or the full face-to-face that will emerge from this. But I defer to my colleagues on their opinion.
I will also add to that before I invite also Dr. Weidner and Dr. Abraham, if he's still here, is just as Dr. Haft said, this is a learning curve, right? So we really had not entertained a lot of things that we're doing now using telemedicine. So I think that some of the answers lie here with us who are in this room on this webinar. And I would not be surprised that there will be, pockets of, task forces or committees coming together because until you actually do it, can you actually give feedback that, this actually works, this is another option, this is a preferred option. And I think when the science supports the healthcare outcomes and impact and access to for patients to care that they need, I think we can keep making the case for how things can evolve over time. So let me also invite Dr. Weidner and Dr. Abraham to speak to that if he's still here.
Yeah, I can talk to that. This is Joe Weidner. I think we're finding that it makes sense for a lot of people, and I think for some people they may be more engaged with having a telemedicine visit and especially if they were previously not as inclined to come into the office for follow-up. I think certainly depending on the amount of community COVID and the risk of getting it in certain places, we may want to minimize their trips out to the office. Although I think with any given visit with a telemedicine visit, it really can be discouraging depending on the connectivity and just the bandwidth that people have between whatever device and connectivity they're using and ours. So sometimes, and not infrequently, it's less than ideal visualization of things and interaction. And but then it can be a start too. So I think this type of mesh of a visit where you may start with a telemedicine visit and then follow up later on with a physical visit, or having some sort of mixed type of visit, is something that we're finding that works at times. But still, I think it's less than ideal. And you think about at times where you've picked up that atrial fibrillation on somebody who's been asymptomatic, or you're just doing a follow-up visit for hypertension, or you're picking up some other physical finding that you otherwise wouldn't without symptoms, how much are you going to really miss by routinely doing telemedicine visits for follow-ups for people with chronic disease who are at risk to have other complications too? Those are the things that go around in my noggin when I think about the ongoing use of telemedicine. But I think we're finding a bigger and bigger role to use it on an ongoing basis with people, and we'll continue to do that.
So for our practice, before COVID and before the pandemic, we were using telemedicine visits, and we plan on doing so currently and after the pandemic is over.
All right, thank you everybody for your responses. That wraps up the Q&A session, so I will hand it back over to Angelica.
Great, thank you. Now, I know there were a lot of good questions that came through, and we'll be sure to follow up on the questions we didn't get a chance to address. And do appreciate you staying over the time that we were projected to end. I know we're a couple minutes over, but there are some items that I wanted to run through really quick before I turn it over to Dr. Okeke and Dr. Half for the closing remarks. So again, the slides that we shared, they are available for download in the handout section. So if you go to the webinar control panel, you should be able to see the handout and download it. And when you do download the document, you will have access to the links and also videos that were shared. I know there was one video shared, but there are other videos within the PowerPoint presentation that we didn't share, but wanted to provide that as a resource to you all. So when we end the webinar, once you X out of the platform, post survey with about 6 questions will pop up. So please, again, take some time to fill that out. And then another thing regarding the CME credit. So there will be a follow-up email, and you'll receive that after the webinar ends, shortly after the webinar ends. And it will provide instructions on applying for the CME. There will be a link to a form that you'll need to fill out. So look out for that if you are interested in applying for the CME. Again, for non-physicians, you can apply as well, and you'll just want to check with your credentialing organization to see if they do accept the CME credits. So those are all the reminders I had. I do want to thank you very much for joining and hope this training was insightful. And I also want to give a special thank you to our awesome speakers and our guest speakers. I think they did a phenomenal job with this training. And I hope everybody has a good rest of their week. And with that said, for me, I'll turn it over to Dr. Okeke and Dr. Half for closing remarks.
I will let Dr. have the last word. I just want to say thank you to you, Angelica, and Ashley for being great hosts for this event. Again, thank you to all of you who were here to participate. Thank you for your questions. For those questions again that weren't answered, we'll try to answer those and see if we can work with Dr. Haft and his team to put something out there in their weekly newsletter that goes out. For those of you in the MDPCP program, that could be posted on Connect. So thank you, Chastity, Dr. Abraham, Dr. Weidner, as well for being here. So I will just hand this over to Dr. Haft to close us out, but thank you all for all you do every day. You are our healthcare heroes, and we hope that we can meet again to keep having this conversation about how we safely reopen primary care in Maryland. Dr. Haft?
Yeah, and Kim, I could not have said it any better. Thanks to everyone. Thanks to all the work that everybody's put into putting this together. And thanks to the creativity of all and the ability to stay within these very broad but changing guidelines for all of our providers across the state, who I know do this every day with their patient's best interest in mind, and do it despite the hardships and everything else. So God bless you all and have a great day.